So today I will tell you about the novel therapies in Huntington disease. However, I will start with some notes about Huntington disease in general. I have nothing to declare. First, about the story about this disease very shortly. This disease was described many times in the past. However, most detailed description was prepared in 1872 by George Huntington. He published first a full description of the disease, and this disease, after his name, was called Huntington's chorea. Earlier, it was called chorea or San Vitius dance in Middle Ages. A few words about George Huntington. He was an American doctor living on Long Island, and actually his place where he was settled for longer was East Hampton. He published just one paper in Medical and Surgical Report, and on chorea, it was enough for him to become famous around the world. So, Huntington disease, change of name resulted from a clinical characteristic of this disease. So the name changed after years when we realized that Huntington disease is not only chorea, but accompany also other syndromes. And we decided to change chorea into disease. So I will now always use the proper name for this disease, namely Huntington's disease. So this is very rare disease, and just 4 up to 10 cases per 10,000 Caucasian population. Of course, taking into account pre-manifest individuals is a little bit more, but in other races, it's a less prevalent disease. Onset of symptoms of the genetically conditioned disease appear between 30 and 50 years, usually. However, we have also younger patients who start very early, even in age of 2 years, or very late, after 70. So both forms are very rare, but also different than classic presentation of this disease. In Westphal variant, the clinical phenomenology is very different. We have more stiffness, more dystonia, more other symptoms than only movement disturbances. And in senile form, we have mostly chorea and slow progression. So, as I told you before, in the past, this was called San Vitius dance or Huntington's chorea, but after we realized of other symptoms, not only motor symptoms, not only chorea, we decided to change the name of this disease into Huntington disease. So what kind of symptoms are present during course of this disease? First symptoms at onset, or the disease could start with motor symptoms, with chorea, dystonia, stiffness, walking problems, or dysarthria. Could also start with oculomotor symptoms, especially juvenile form is typically starting with problems with with these symptoms and eyes movement. Very often, this disease starts with cognitive symptoms. It's subcortical dementia. It's different dementia than in Alzheimer's disease. Here, in this disease, we have slowness in thinking and problems with construction of procedures. So it looks like very strange when you compare it with Alzheimer's disease, and these patients are perceived as people who think very slowly, and they can answer your question in the right, proper way, but after a longer time. Next, behavioral disorders. It's very often this disease starts with depression. So depression could be first symptoms of Huntington disease. However, it is not pathognomic for Huntington disease, as you know. Depression could appear very often independently from Huntington disease. It's common disorder. So we are not able to establish that the depression background is Huntington disease. Often also it starts with aggression or irritability and aggression, and sometimes, quite rarely, with apathy. Of course, this disease could start with mixed symptoms, so motor and cognitive, motor and behavioral, or motor, cognitive, and behavioral. So also this happened. And here you have symptoms appearing in course of Huntington disease. First, involuntary movements. It's usually official start of symptoms in Huntington disease because without involuntary movements, typical for Huntington disease, we cannot be sure that what we see is really Huntington disease. So we understand involuntary movements, namely chorea and dystonia, eyes movement problems, as onset of Huntington disease. And very early after that, we can see coming depression, coming sadness, clumsy, lack of motivation, so apathy, sexual troubles, sometimes very rarely paranoia, sleep trouble, of course, delusions very rarely. In the middle disease, of course, problems with walking appear, and weight loss. This is a quite typical symptom. It could appear very late in course of the disease, but also at the beginning. So this list here shows different symptoms that could appear, but it not give us a rule how late these symptoms will appear. So all symptomatic domains of Huntington disease consist of movement disorder, behavioral syndrome, cognitive syndrome, and metabolic disturbances. And here you have a frequency of and problems generated by particular symptoms. And here, for example, chorea is one of the most prominent symptoms that generate several problems. Symptoms secondary fluctuate in the course of disease. Psychiatric symptoms can appear, and these appear often. It's not always related to effective treatment. Motor symptoms are represented by hyperkinetic, choretic movements, increasing from the onset until late stage, when are replaced by increasing stiffness and bradykinesia. And cognitive symptoms usually increase slowly, steadily in course of Huntington disease. And metabolic problems, as I show you, appear usually suddenly in course of disease, sometimes at the beginning, sometimes at the end of the course of this disease. Where we are able to treat some symptoms, only symptomatic treatment is available at the moment, and we are able to treat motor symptoms and most of psychiatric symptoms, excluding apathy. Apathy and cognition are not possible to treat at the moment. Treatment for Alzheimer's disease does not work in Huntington disease, so you cannot transfer these medications. And apathy also, unfortunately, doesn't react for therapy usually applied to treat apathy. Of course, very important is multidisciplinary care. It means rehabilitation, speech therapy, very important, psychological assessment and support. This should include also caregivers of HD patients. Remember that caregivers very often are family members of patients, and they are, first of all, burdened very much by care of HD patients. Moreover, they could be at risk of Huntington disease because, as I told you before, this is genetically conditioned disorders. At the moment, we haven't disease-modifying therapies. You can also find symptomatic therapy algorithms in my paper published in 2018. We haven't too much changes from this time because we have novel medicines used to treat symptomatically Huntington disease. And this is course of in a patient. You can see brown line. The brown line indicates signs and symptoms. And as you see, these are not present until middle age, usually. After neuronal aggregates accumulation, this aggregates consist of Huntington, a protein produced by mutated allele of HTT gene that I will explain you in few moments, result in neuronal dysfunction and later neuronal death. Just when neuronal dysfunction appear, then also first signs of this disease are visible. These signs are visible many years before symptoms onset, but require special techniques to observe it. So these are not symptoms that each one neurologist can observe and identify onset of Huntington disease. The onset appear later when you see the brown line is crossing a green breaking line. This cross line indicate the onset of this disease. As you see a dark green line upstairs, you can observe appearance of suicidal ideations and suicidal attempts. So at the beginning, just before onset of HD, you have a peak for suicidal ideation and suicidal attempts. And later, in stage 2, when patients become less independent and start to be dependent from caregivers, many patients decide to commit suicide. Of course, suicidal ideation are very often in Huntington disease, and it's part of psychiatric symptoms. However, it's very often also independent from depression. So it rather impulsive action that is not inhibited. And these suicidal attempts appear very often suddenly. Nobody expected because this patient is not sad. It's nothing happened, but suddenly committing suicide. And here you have an example of a patient who is affected with Huntington disease and some data about survival with this disease. It's the same lady. On the left-hand side, you can see the lady at the beginning, at onset of Huntington disease in 1985. After 13 years, you can see the same lady on the right-hand side. So this lady is from Venezuelan cohort. These people living on Maracaibo Lake in Venezuela. And as you can imagine, they have very limited access to any kind of medical support. So no rehabilitation, no other support was available for her. But it shows how fast this can progress. Right now, due to rehabilitation, speech therapy, medication implementation, lifetime is longer, and disease duration is from 15 up to 30 years. Mean survival after manifestation is 21 years. Also, gender difference we observed in Huntington disease, and you can see that in ladies, this disease is faster than in men, and the progression of the disease is faster, resulting in shorter time to dependence from caregiver. And now, most important part about genetics of Huntington disease. As you see, this disease is conditioned by one gene. This is HTT gene. In the past, you can find that it was named IT15, interesting transfer 15. This old name was generated in 1993 when a gene responsible for Huntington disease was identified. And after time, we decided to change this name from IT15 into HTT. It means Huntington, because this gene is responsible to generate Huntington, a protein that is produced by this gene, and we still are not fully conscious what is role of Huntington, but this role seems to be very important. Lack of Huntington could have a negative impact on people. Also, mutated Huntington is, of course, a result that generate Huntington disease. This disease is transferred in autosomal dominant manner. It's fully penetrant. So each person who has such mutated gene should be affected by Huntington disease. It means also that everyone has 50% of chance having Huntington disease when his or her parent is affected by Huntington disease. It means also that for you as doctors, it's easy to collect interview and see and that in the family Huntington disease appeared in prior generations. Moreover, this mutation responsible for Huntington disease is called dynamic mutation. Why dynamic? As you see below, this mutation could be larger or smaller. It means that it consists of a repetitive sequence of CAG nucleotides in exon 1 of Huntington gene. And this part, CAG repeats sequence, could expand. So we can have more repetitions. And if this number of these repetitions will exceed 35, then we can expect that this person will be affected with Huntington disease. If we have more than 40, then we can be sure that this person will be affected by Huntington disease during normal lifetime. Of course, more repeats mean earlier onset and faster progression. So juvenile onset appear when, for example, we have more than 50, more than 60 CAG repeats. When senile onset appear usually when you have less than 40, so somewhere between 35 and 40 CAG repeats. Of course, we are not able age of onset and rate of progression having only CAG repeats number in blood cell. It's impossible because we identified also another factors, usually genes, other genes responsible for modifying age of onset, would mean that, as you can see on the diagram on the right-hand side, the age of the onset could appear 15 years prior to predicted onset based on CAG repeats number, or 15 years earlier. Because all genes contribute significantly to age of onset. Of course, the role of Huntington is not very well identified. We know something about it. First of all, it builds aggregates, as you can see on the diagram below, and it also modifies action of another genes, namely the expressions, and this result in different production of different proteins and global changes in cells. Okay, so having it, but this is genetically conditioned disorder, we can expect how we should treat this disease. So it generates some therapeutic expectation. In 1993, we expected that we will find therapy for Huntington disease very quickly because we know gene responsible for this disease. So it's very easy to turn off this gene. Well, it's about 30 years after that, and we still are not able to turn off this gene. However, we are much closer to this than before. So, what are conceptions of fixing the root cause of monogenetic disorders? For example, supplying or missing 40 gene product, but this address mostly to autosomal recessive or X-linked disorders. But silencing or suppressing of a mutant allele is addressed to autosomal dominant disorders with gain-of-function mechanism. And this is first what we think to apply in Huntington disease. Another option is gene editing, namely correcting the genetic defect at the DNA level. It's applied to all monogenetic disorders. And well, we expect that especially gene editing could result in the fact that just one treatment session may be sufficient for life. So one time only application of therapy. So we have plenty of strategies for Huntington disease, as you can see here. We can break production of mutant Huntington at different stages. Most promising are these addressed to DNA. Of course, Zinc Fingers gene silencing is one of the most interesting and most important. And another option is CRISPR-Cas9 as gene editing technology applied just once and changing gene structure. Another option is RNA silencing, and here Antisense oligonucleotides, microRNA or siRNA could be applied to do it. Moreover, we have some oral anti-splicing therapeutics that disturb splicing of mRNA for Huntington disease. I will show you later these attempts. Next, we have anti-aggregation approach, proteasome modifiers, epigenetic inhibitors. So plenty of tools that we could use to treat Huntington disease. But we have still open question. What to deliver to affected individual? How to deliver? And when to deliver? These open questions need to be addressed before we will start efficient therapy for Huntington disease. So, first of all, we need to transfer therapy from cells to animals and to humans. Of course, as you can see on this picture, there's brain size problem because it's quite easy to apply treatment in small animals. In larger animals, it is more difficult. But in human, brain size is huge. And remember that HD is a brain disease mostly. Therefore, if we would like to deliver treatment to the brain, we need to use efficient method to really do it. So, in vivo gene therapy approaches. Of course, these approaches differ with respect to cargo, what is inside, namely, so code of therapeutic RNA, microRNA, zinc fingers, Cas9 case, etc. So different inside. Of course, also vector system employed. And here, for example, AAV viruses, capsids of viruses used to transfer RNA, for example, or nanoparticles. Next issue to resolve is route of administration. For example, intraparenchymal injections into the brain. So we can inject the brain, we can provide this treatment to cerebrospinal fluid, and of course, we could use systemic intravenous administration, what is most interesting because it results in a very good distribution of treatment across the body, and also to treat other tissue of the organism, because not only brain is affected, also muscle, also heart. Other tissue treatment is also important. And currently, most interesting is adeno-associated virus vectors, and you can see it on this picture on the right-hand side. And of course, it is the capacity of this is enough to pack RNA, for example, that could be expressed in cells and could act in cells. You can also pack DNA to this virus, so you can use it as very good vector. Such virus is treat or to modify SMN1 gene, as you can see on this picture. What's very important is capsid engineering, and you can see it here. Moreover, size targeting, crossing the brain-blood barrier, limiting off-target transduction, for example, liver, of course, and avoid dose-dependent adverse effects. It's high transduction efficiency, and to escape pre-existing immunity, because if we repeat this treatment, then very important is to protect this vector against immune system of the body of the host where we want to deliver. And very important is also to cross blood-brain barrier. And according to Smith, in those published in this year, approximately 10 up to 15% of all cells were transduced with neuronal transduction efficiencies ranging from 5% to 15%. Estimates that were similar across brain regions. Dosage per cell is also important. Once a cell is transduced, there's no more control over dosage of the therapeutic agents, and for non-allele selective approaches, it will be of interest to establish the percentage of cells neurons with no or very low expression levels of Huntington. And another way to deliver it, we can deliver it directly to central nervous system parenchyma, and you can see such catheter could be used as a pipe to deliver AAV to target, to part of the brain that we would like to reach. Of course, this results in some toxicity risks, and as you can see, places where the treatment was delivered changed. And you can see inflammation or edema in these places after transfer of vector directly to brain parenchyma. It fortunately doesn't result in clinical correlates, but it can be observed in MRI, and we are worried that it could result in some problems in the future. And the last question, when therapeutic intervention? And well, these signs, as I showed you before, appear in middle age, for subjective origin, then clinical diagnosis, but many years before, healthy neurons disappear. So the neuronal dysfunction appears earlier in the course before onset of this disease. And the right time to apply the therapy is somewhere between, well, beginning of significant neuronal dysfunction and onset of symptoms. At the moment, in clinical trials, we need to apply therapy in patients who are symptomatic already, because we need to check whether this medication modify course of this disease. For example, stop progression or reduce Huntington level. So let's go to clinical trials and ideas. Here in the on the screen, you can see history of genotherapy. So we are more and more advanced in this. It was published in 2013, so we are much far right now. So I will show you what we are able to do now. First of all, what was not efficient, checked but not efficient in treatment of Huntington disease. As you can see here, this year we finished 2 clinical trials with first attempt to genotherapy in Huntington disease, namely gene silencing therapy with application of antisense oligonucleotides. There are 2 companies, Wave Life Sciences and Roche, and these 2 companies applied clinical trials in human affected with Huntington disease, Wave phase 1 and 2, and Roche phase 3. The antisense oligonucleotides was short RNA, and role of this short RNA was to disturb or destroy production of mRNA of HTT gene. In Wave, this therapy was allele specific. It meant that it affected only mutated allele. And of course, we expected that it will reduce level of only mutated Huntington. Unfortunately, this not happened in our patient with Huntington disease, and no improvement was observed. In a Roche study, antisense of oligonucleotides was allele non-specific. It means that these antisense oligonucleotides destroyed mRNA of a normal wild-type allele and also mutated allele. And here we observed that after application of this treatment, patients, 790 patients across all the world, much faster progress than these who receive placebo. It means that this treatment accelerated Huntington disease instead of stop it. So probably it results from the fact that this normal Huntington is very important to support a function of our body. So both studies were dramatically stopped in March this year. But we still are on track and still try some new ideas. Right now is ongoing uniQure treatment. Oh, one more important fact. Both Roche and Wave studies applied antisense oligonucleotides directly intrathecally. And maybe it was also a reason why it was not very well distributed across brain. So uniQure is another company that tried to implement also small RNA, microRNA, and the role of microRNA is very similar to antisense oligonucleotides, namely to destroy mRNA of Huntington. This trial is also allele non-specific. It means that it affects both normal Huntington and mutated Huntington. But here there's a different way of injection of this medicine in the body, namely directly to putamen and caudate nucleus. This microRNA is encapsulated in a AAV5 virus. And this capsid transfer microRNA directly to putamen and caudate nucleus. Authors of the study expect that this direct delivery will result in better distribution of the treatment across the brain and will result in higher suppression of production of Huntington, both mutated Huntington and normal Huntington. And they expect that after implementation of this treatment, this disease will start to be slower. The progression should be slower. And they intend to observe patients for 5 years after one intrabrain injections of microRNA. We will see the results because this study is ongoing right now. Another very interesting conception and allele specific is Zinc Finger's technology application to treat Huntington disease. And here you have very efficient way to stop expression of mutated HTT gene. This is allele specific and it acts on DNA. It means that application, we expect that we will apply this treatment directly to the brain. We will observe very good distribution across the brain and a very efficient connection of zinc fingers to DNA. So, of course, this is allele specific, therefore, normal allele of HTT gene will work normally. We, based on experiments in lab animals, that will be able to very efficiently stop production of mutated Huntington in human, and this will result in very efficient therapy, reducing progression of Huntington disease. As you can see, based on the animal studies, we obtained very good results using experimental method in animals. Next year, we expect a new trial based on humans. Another very interesting way how to treat Huntington disease is CRISPR-Cas9 mediated gene editing, and it was also shown in 2017 that it stopped this disease in lab animals. This method is also allele specific, so we edit mutated gene only, mutated allele only, and we do not disturb normal allele. This, of course, this way of treatment was developed much earlier by two ladies. Last year, these ladies were Nobel Prize winners in chemistry. They developed it to modify food, actually, called GMO. So the first usage of this method was not to treat people. We later, after discovering of this mechanism, first in bacteria, but these two ladies, and implementation into food modification or plants and modification, actually, we realized that we could use it also to edit genes in human to treat some diseases. And of course, it's a very promising method, but we experience one problem with this method, namely off-target action. It means that this gene editing that should be realized by CRISPR-Cas9 sometimes directed to wrong place in genome. It means that it modify not HTT gene, but another gene in our body, disturbing this gene, destroying it, or leading to malfunction of this gene. Of course, only one application of this therapy, when it will be efficient and safe, will be enough to treat mutation in gene, and as expected, it will reverse course of the disease. So this could be very promising therapy for future. And another ways how to modify course of Huntington disease. Here you have application of therapy to gene that modify course or onset of Huntington disease. Some genes like that were identified. One gene is FAN1, another is MSH3, and these genes were identified as responsible for elongation or expansion of CAG repeats in genome in cells of people affected with Huntington disease. So applying such therapy, here called TTX3360, the Therapeutics company expect that they could were a reduced number of CAG repeats, and then they could in safe way lead to clinical improvement in human. This was not yet applied in human, but this is planned for next year to apply this treatment. Of course, it could be addressed not only to Huntington disease, but also to other repeat disorders. So all disorders with dynamic mutation like spinocerebellar, ataxia, and other diseases. Another way, here you have very interesting attempt by Novartis to modify splicing of mRNA of mutated HTT allele, and most interesting and important in this therapy is administration of this therapy. Namely, it's oral administration. Unfortunately, this is allele non-specific, but very easy to administer. And this treatment with small molecule should result in the fact that in process of MRI preparation, one more part will be present in produced mRNA called pseudoexon that will incorporate and start production of mRNA. And another very similar trial here by PTC, also oral administration and also splicing small molecule that could disturb splicing of mRNA of HTT gene, and also this method is not allele selective. At the end, I would like to show you also some new clinical trials for symptomatic treatment. These two trials already started. One is with use of treatment of medicine used to treat arterial hypertension. It's very commonly used medication, bevantolol, and here some biotech intend to try as a potent VMAT2 inhibitor, very similar to tetrabenazine in action, to reduce chorea in Huntington disease. So this is symptomatic treatment, but it should result in the fact that they will avoid some side effects of tetrabenazine like depression and suicide ideation. Another option for symptomatic treatment is predopidine, and here another company, Prelenia, intend to try sigma-1 receptor inhibitor to reduce chorea in HD patients. This medication was tried in several, about 6 previous huge trials, and never showed beneficial effect, but some effects were controversial. Therefore, Prelenia intend to try it once again as a treatment for Huntington disease. Thank you very much. Do you have any question? Then I open to answer it.